I would have to accept to be here because of the topic at stake. I was going to query the name. Joy FM had decided to add Yao to my name. And for those who don't know, Yao is a Thursday born. I'm a Saturday born. But Evans Mensah would always introduce me, Nana Yahweh Free. And I always protest vehemently on air. Today, my senior has also added a Yao. But it's not to say that just about a month ago, I went for a festival in Mampoekwapem, my father's hometown. And there again, too, they said, Nana Yahweh, you were free. I said, no problem, Joy FM has done it again. So it's going. But just to put on record, I'm not Yao. The name is a U, and I don't know how sometimes the U becomes Yao. Thank you very much. So Ivan Spencer, my brother of long standing, you see. So basically, it is imperative for me to say that Transform Health initiative is crucial and has come at the right moment. And gathering as this to create awareness, to bring stakeholders together, to share knowledge, to gain experiences from elsewhere, and to help us in charting our path towards the use of digital health in achieving universal health coverage is so much appropriate. And it's on this note that I realized that however much that I need to be in Parliament, I also have to be here, because whether it's going to be e-levy, which is going to be digital taxation, whether the budget to be approved, whatever it is, we are at the crossroad where there is no turning back. We are at the point where mobile health would have to be integrated in the delivery of health services. We are at the point where e-health will have to be integrated. We are at the point where emergency medical records, people who live in my village in Kwankwe at Efijase, and when they go into Konfanoche, they always give them their folder to take it there. The access from that place and the terrain to where they have to go. And sometimes their folders, you can't find them. So the benefits of digital health is enormous. So much so that we need all to come on board to put in that driving force. We need capacity building. Last year, when they came to Parliament for budgetary approval, members in Parliament Health Committee raised issues with the financing of emergency records that was piloted under the NDC. And it's my
Hello, my name is Abeku Agri Santana. If there's anything that makes my life so easy, it is my bank. I love hanging out with my boys at our usual fufu joint. But even without cash, we still dey chop better with Ecobank Mobile. No matter the time of day, my bank helps me stay in touch with my beautiful wife whenever she's away. And when my beautiful wife is in town, she never misses out on her favorite TV shows because I'm able to pay up all my TV subscriptions from the comfort of my mobile phone. Whenever she has to get groceries too, my bank makes it cashless and convenient. And the part my wife loves the most is when my bank makes it possible and easy for her to shop from any part of the world without moving.
Welcome to the smart world of Ecobank. Download Ecobank Mobile from Google Play Store or the App Store and discover the smart way to bank. Ecobank, the Pan-African Bank.
Yamwakwa baba kase boyso. Efra me vim lady, efia pokia. And then we are say you, and some say yare also, and ketsuani akese. And I'm so me ebusan for say, apomudin ma papa. And he say,
apomudin say, Oba boy Juma aqua ba unti brebia.
One dem rosro. So be sipi sita. Ana. So be bo heavy. Debia.
Oh you are Obia fa hodin, Obia penkwa, edroni ni. HeFRA Plus mixture. We na ono mo a enkwa mo na nya ahode akweti anyare wo bia ebeba oni pedua ni. HeFRA Plus mixture e ma apomode mapa.
HeFRA Plus mixture e bo ma ni pedua ni gina yie pa. HeFRA Plus mixture enye mankwa na wondi fiedu mienu apemfo ana batai.
FDA ati ejadie nkratwe atu.
HeFRA Plus mixture e ma apomode mapa.
I am going to take us through something the NHIS did around using digital technology to completely change what we do. And it's been a game changer for us. First of all, I'd like to look at the background. The story so far in healthcare delivery. 57 to about 1970, we had universal healthcare before anybody had even thought of the word universal healthcare. But in the 70s, financial issues came up and a minimum token was introduced to receive health. By the 80s, we were in full-blown cash and carry. And that was when I was a medical doctor, and it was the most painful part of my career. So by the 90s, we started experimenting with community health insurance. And in 2003, the NHIS was born. The law was amended in 2012. And really, it has the goal of universal health care in Ghana, equity, everybody having access to care with no cost at the point of use. That is the critical part we must all remember. At the time you are sick, that is not the time to ask for money. Now, our finances are through a combination of tax, payroll, and premiums. So it's the only social health insurance in the world using all combination of finances. And it's distributed through a network of about 172 branches. We have inpatient, outpatient medicines, and diagnostics. But the point is, we achieved about 40% of active membership and got stuck. So in 2017, the NHIS, with the support from the ILO Impact Insurance Facility, decided we had to use digital means to change the way people register and renew. And this was us before we started, and I'd like us to keep in mind certain things. The informal sector never rose more than 29%. So the period preceding mobile renewal, the enrollment and renewal process in our offices was only in our offices. And each office, with the best will in the world, could do about 60,000 registrations or renewals per annum. Now, if you have about 160-something offices, with the best will in the world, you will always manage 10 to 11 million, and we are 30 million. We had to come up with something else. Meanwhile, the media always taking pictures of our offices with people queuing, sleeping on mattresses, which didn't help our cause. Long queues. There was no way to notify people of their expiry. You get to a clinic and they'll tell you, oh, your card died 2 days ago. You have to go all the way back to the district office within consequent transport costs. So we needed to find a solution. So our strategy was, we need to design an efficient digital renewal process that would help our users. The digital solution needed to reduce our operational costs and burden. And we needed to expand this to include some kind of authentication. So all three, whatever solution we needed to come up with, all three sort of problems had to be solved with that one solution. How did we do it? We used what we call design thinking. So the first thing was to interact with all those who are affected. That's our staff, the public, and the providers, to really define the problem well. Then the next thing is, once you've defined it and really looked at what part is the crucial problem, you begin to come up with solutions. And I'm going to be honest with you, when they started, I was kind of the supervisor, and I really didn't see where they were going with this at all. And I think my skepticism was a bit clear. But they were determined, and they went back and forth between the office, the members, and the providers, trying to come up with a solution. And we must have gone through about 4 different plans. But what was eventually settled on, we decided to quickly put it on mobile phones and test it out. And the members loved it. And they will find a little fault, we'll come back and fix it. And in the end, we tested it in 2 pilot areas, one very rural up north in the northeast, and one pseudo-rural in the eastern region. And so the solution was in 3 parts. The first thing is, if it is digital, we can send SMS reminders. That's the first thing. The second is that the members were insistent that whatever solution, they wanted to be in total control. So it was the members doing it themselves on their mobile phones. And the third thing is, now that we're not printing, how do the hospitals authenticate to know you are active before providing services? So we had to come up with a digital authentication. So that was the 3-pronged approach. And this is it. All you do is dial *929# on any phone. It's not an Android. It works on a YAM phone. And you can check your policy expiry. You can renew your membership. You even get some ideas about the benefit package and the medicines list. And of course, we've now added the linkage to the Ghana card. And as the expiry dates are not printed on the back of the card anymore, we needed an authentication cycle. So this is a different code. It is only available to facilities who are credentialed with the NHIS. Your phone number is registered with us, so it can't be done by anybody else's phone. And when you try to authenticate, you will get a code that allows you to submit a claim for that patient. And when you submit the claims, our system then double checks the code, the patient number, and the date. If all 3 don't synchronize, the claim will not be accepted. And this is what happens when you try to authenticate. We want the people of Ghana to be citizens and not spectators. So not only do we send a message to the provider, which gives them whether the person is active or inactive. If you are inactive, you don't get a code to be able to submit a claim. If you are active, you get a code and the person's details to help you. We also send a message to the member, and it will tell you the hospital that is actually trying to take money in your name. And all you have to do is press the number 2 on your phone. We don't want you to go through any long stress. That alerts us that this member says they are not at the facility. We don't just reject the claim. It's about investigation, checking the trends. So what has been the impact for us? It's reduced waiting time. I defy anybody to show a picture of any of our offices with long queues anymore. It happens a bit when school reopens and people want to quickly renew the awards NHIS membership. But on the whole, after 2 o'clock, our staff are now free to go out and do monitoring at provider sites. It's reduced transportation costs. An unexpected benefit has been reduction in lost income. If you are a tomato seller in the market, can you afford to spend the whole day queuing at an NHIS office to renew your membership and your children? Not at all. People like that, the informal sector, are very reluctant to go and renew and queue. This is a thing of the past. We send membership expiry reminders, and what it has done, I think, is increase the engagement between the scheme and the public. And the public are a lot more interested in being part of the scheme, asking us questions and getting involved because they are a bit more in control of their own destiny. We did a survey of 300 members in the pilot district we were working in, and 100% of them said they would recommend the mobile renewal to their friends and family. 98% said the experience was good or excellent. From our investigations, the average time saved was 11 hours. That is the whole working day. And the transportation costs, the average across the country is about 4 cedis saved. This is from the Northeast region, where once we started the pilot, we found groups of people just congregating and teaching each other how to do the mobile renewal. And, there she is telling somebody she was really excited because she'd have had to wait in a queue. She just renewed herself and went back home and left everybody else in the queue. And this person went to the clinic only to be told her membership had expired. But the nurse quickly explained to her that there's mobile renew it if you have Momo on your wallet, which she quickly did herself. And because she hadn't expired for more than 3 months, it was immediately active and she could receive care and get her medicine. For us, it means we have a higher scheme penetration. It has lowered our operational costs. It's given us better claims governance because it isn't that easy to put in fraudulent claims. Therefore, there's a reduction in leakage. There's no money exchange anywhere. It's all happening by mobile money straight into our accounts, which gives us a higher income. And as you can see, the adult informal sector has shot up from 29% to 36%. They are the group that has most benefited from the mobile renewal. But more importantly, our active membership is well over 16 million from always being around 10 million. And that was just in a year or two. Massive, massive impact for the scheme. At very little cost, I must say. Well, we thought the urban people with their flashy mobiles, no. The rural uptake is much, much better. I would have to assume because of the inconvenience, informal sector, transport is not that easily available, and therefore they prefer to do it themselves. The project was ready 6 months ahead of time. In fact, it was ready within a year, but we had to go through some regulatory checks because We are collecting government money. We thought it would take us 5 years to get 50% penetration. We are now between 75 and 80% in most regions. People prefer this digital renewal. So what are some of the lessons we can learn? There's a typo here. I meant to say don't underestimate lower middle income countries where digital technologies are concerned. We always assume that digital technologies work in developed countries. Not true. If you're doing the right thing in our countries for very little cost, we can find digital solutions. If the design is good, it markets itself. The money we got from the French Development Agency was $50,000. We did it with change. And instead of spending huge amounts on marketing, before people had designed WhatsApp flyers, videos on YouTube and all sorts to teach the public how to do it. So we kept our money in our pockets. Stakeholder participation early in the process is efficient. I must confess, this is not what we were thinking about when we first came up with the idea. But it was the public that told us, put something on the mobile phone and we will use it. And they kept refining the design. And therefore, it cost very little money to get a workable prototype because all those involved were involved in the design right from the beginning. And there's no end to the spin-offs. I'm telling you, we have done more and more things based on this one idea of *929#. The authentication. We can now see at the head office how many people in the month, long before the claims come, so we can plan. When COVID came, we realized that for the first month, 1.1 million people did not go to hospital. Usually there are 3 million utilizations a month. April, it dropped to 1.7. And it didn't get back till January this year. So this is long before the claims come, before you see the actual sort of health impact. We know that for more than 6 months, about 1 million visits a month less were happening in our health sector. And this will have a knock-on effect coming forward. So for the NHIA, we are still evolving. We are still exploring the digital health world. And I'd like to tell all of us, we may think we are not as technologically savvy as the rest of the world. Trust me, we have really good solutions going on, and we can have even better solutions going on. And it doesn't cost that much. And once you start, there's no stopping you. Thank you very much.
Thank you very much. Please, a big round of applause for Madam John Selby. I must say, this is really fascinating. And one of the things that caught my attention, Dr. John Selby, is that this cost, what, $50,000, he said? It's amazing. I mean, I've heard millions so much for projects like this. I thought you meant 50 million, so I wanted to check. But that tells you it's possible. It's really great to see that our public institutions are actually taking the lead with digital health also. I have a personal story though, and I'm later on will invite some questions. Recently, just literally last week, my mom wanted to renew hers, and listening to this, I'm just reminds me that a bit more. I guess we need to help the NHIA do a bit more of the advocacy out there, because she didn't know about it. She said she has to go and queue, and so she did the money, and I had to take care. And of course I couldn't, and so I had to arrange. And I was insisting she has to. So apparently because of the fear of the queues, she's not done it for so long. And I only found out last week. Apparently there is a code that she could have just simply used. And you said the code is what? Hash? *929#. *929#. Thank you. Personally, I'm going to send it to her right now and get my siblings to help her do it. But that's...
Do it today.
Oh, yeah, absolutely.
At midnight, the waiver of the 1-month waiting period will close. Today is the
In fact, let me give you a microphone to do this, because I'm sure, like my mom, there are many out there who would like to hear this.
There's usually a 1-month waiting period so that people don't only renew when they need to use the card. But because of the NHIS week, the president allowed us to scrap the 1-month waiting period. It ends today, which is the last day of November. No matter how long you've been inactive, if you use *929# today, you will have instant access to health services. Please share this information and everybody come back on board. Thank you.
Thank you very much. This is really life-saving, I must say. A big round of applause for the NHIA. Great. So let's kick on. This is great start indeed, but there's more, because the NHIS, they work. There are service providers who depend on the systems that the NHIS infrastructure that they've just laid out for us. One of them, in fact, I must say the largest of them when it comes to the non-state provider of health services in Ghana, is the Christian Health Association. It is the largest. And I'm delighted to say that Dr. Peter Yeboah is a chief executive, is an executive director, rather, there. And he's here with us, and he's going to share his own thoughts about how they're also relying on the digital platforms, but also using their own to bring healthcare to all across the country. So, ladies and gentlemen, a round of applause for Dr. Peter Yeboah.
So many thanks, Mr. MC Evans, for validating CHAG in such kind complimentary terms. Honorable Chairman, friends here gathered and those online, coming from the Christian Health Association, naturally I should bring you prayerful greetings and blessings, which is very necessary before I proceed with my presentation. Indeed, service providers are the face of the National Health Insurance Scheme. And so, beyond a viable National Health Insurance Scheme, it is we, the service providers, that are supposed to give meaning to NHIS' overall mission of ensuring equitable access to quality healthcare to all people living in Ghana. And we are very much pleased to fulfill our role as far as that is concerned. Today, CHAG, as the MC rightly introduced, we are the largest and the oldest non-state actor in health, and of course, the second largest provider of health services apart from the government. And we do this to complement the government's overall mission of ensuring access to quality healthcare. So my presentation will be looking at digital innovations for universal health coverage, how is CHAG leveraging digital solutions to addressing systemic challenges by way of ensuring that everyone living in Ghana has access to quality, affordable, and equitable healthcare. Yes. So my presentation will be looking at digital innovations for universal health coverage, the experience of CHAG, and to the question that we are being asked, in a digital age, what can we do to make it happen? Honorable Chairman, this is highly feasible. So I'll be looking at the context of our intervention as far as digital technology is concerned, the distinctive features of our intervention, the benefits thereof, and challenges that are associated, and of course, zoning on the prospects and potentials for digital innovations. It is our contention that indeed having effective and efficient supply chain system is a pathway for attaining or accelerating progress towards universal health coverage. Sorry, IT challenge. We will definitely overcome IT challenge. That is why we are here. Please, could you? Okay. This one. Very well. Ghana, together with the global community, had signed on to the UAC roadmap. And the UAC roadmap, simply from the perspective of our Honorable Minister of Health, is intended to ensure timely access to high-quality health services to everyone living in Ghana at the point of need, without any restrictions, or if you have any financial barrier, you are entitled to high-quality, timely healthcare services. And this aligns with Sustainable Development Goals, which is about Goal 3, which looks at good health and well-being. And good health and well-being is feasible only when you have access to affordable vaccines and quality medicines for anyone wishing to access healthcare services. In our health system, Ghana, which is making strides, we still believe that having access to quality, affordable, high-standard medicines is indeed some challenge. And let me give a brief highlight on what some of these challenges are as far as access to medicines are concerned. Ghana is always proud to highlight the fact that we are pioneers in several innovations in Africa. One is that we're the first country south of the Sahara to attain independence. And of course, we are also very happy that we have begun something highly innovative, the National Health Insurance Scheme, the best in Africa, and indeed one of the reference points for any country wishing to adopt a health insurance scheme. But on this occasion, we are also recognized with an unenviable record as one of the countries that ranks first with high cost of medicines. And I believe that that is not a good record. And rightly so. It's a global phenomenon, but especially in West Africa, we are also experiencing, or we have cases of substandard, spurious, counterfeit medicines. It means the issue of quality, is a concern. And this naturally affects access to health services that all of us pray for. Often within our healthcare systems, some or most service providers are not nuanced in inventory management, in forecasting, and therefore you have instances of stockouts of essential prescription medicines at the point of need. And so with all these challenges, the question we began to ask ourselves is how can we make a feasible intervention to address these systemic challenges of access, quality, in order to ensure that we play our complementary role of promoting or accelerating universal health coverage. So in collaboration with PharmAccess and then other partners mainly, we felt that exploring digital solutions to supply chain issues was very relevant, was highly feasible. And so the Med for All was born, christened, and launched way back pre-COVID, November 2019. So the Med for All simply is a digital marketplace that has interactive platform and that has accredited suppliers and healthcare providers, in this case, CHAG member institutions, having interactions, and then there are exchanges, and it has this integrated software that ensure that seamless procurement or supply chain functions comprising ordering, procurement, contract management, ticketing, as well as delivery systems at endpoints. So we began in 2019, but before then, we felt that being well informed before you adopt any intervention was very necessary. So in collaboration with Noguchi, some research was conducted within our system to establish precisely what the issues were as far as effective supply chain systems are concerned. And indeed, we came out to a conclusion that if we digitalize supply chain systems, it will definitely enhance the procurement, distribution, and indeed use of medicines that are required. So the digital marketplace, that is a Med for All, has certain features I would like to highlight. First, it has electronic access to price list. If you enter that digital platform later, we'll demonstrate how it appears. You have access to all the price list medicines in the open market. Often, you don't have access to the price list. You may have to go there and negotiate. On the digital platform, the price list is there. And then you also have inventory of all the medicines that are available. Elsewhere, once a supplier wins the contract, there's no guarantee that the medicines are available. In this case, all the medicines that are required are available. And so we are always looking at how can we, together with suppliers and service providers, ensure that we harness digital services. So service providers are then able to forecast their need to enhance forecast purchasing. And then suppliers too are able to know precisely the amount of orders that will be needed within a couple of months. So it helps with lead time as far as delivery of ordered medicines are concerned. So far, because we negotiate in bulk because of the volumes, we are seeing 20 to 30% price cuts, that is significant reduction as compared to the prevailing market price. And this is established. Digitizing supply chain systems, coming together, negotiating, remove certain human interface that I will explain very soon. Don't start assuming anything, but definitely it has a lot of intuitive benefits. So 20 to 30% price cut. And then the Med for All program also has a vital financing mechanism. If there's no financing mechanism, that would be very difficult. One of the key challenges of service providers are their inability to pay on time what they order from suppliers. And naturally, suppliers too, wishing to equalize their income, would definitely have to adjust prices, and that has led oftentimes to high prices. So the Med for All program has financing mechanism that have interest-free revolving fund, meaning that if a service provider that is participating in the program orders any medicine worth 100,000, there's a special financial provision for that, and interest-free. Hopefully, all the participating facilities are credible enough to fulfill their pledge to pay. And thus far, many health providers that are participating in the program have benefited very well on that. Now, this is a schematic presentation of all the vital components of the Med for All program, and I'll attempt to explain for those who are nuanced with diagrams and the rest. Kindly focus a bit. This has all the key components of a smart supply chain system, and that is embedded in the Med for All program. You find that in the middle, we have the right wing and the left wing. In the middle is pricing and market making. Pricing is very important because they need to ensure affordability in the provision of quality medicines is very vital. So in it is negotiation with suppliers on pricing so that providers are able to get the 20-30% benefit in cost reduction as far as procurement is concerned. And also, with respect to suppliers, they are also able to ensure that with predictable orders, they're able to reduce their prices and then also it enhances production. If you're sure that within certain time frame, providers would place order and you supply, naturally it aids with pricing mechanism. And then also business model. The Med for All is very much interested in business model. Even though CHAG is a Christian institution, we are non-profit, not for profit, but we are not also for loss. We adopt business means for Christian ends, and I thought you clap for that, amen on that. So we always embrace business model. And in the application, there's an inherent capability for predictive data analytics that's able to enhance forecasting for purchasing and supply at all levels. And in it is also a control tower. The ordering process has 3 key actors. You have the initiator, you have the approver, you also have the payer. So there's a control tower that ensures that all the processes involved are enhanced. On the extreme left is also a help desk. We believe strongly that not all of us are nuanced in technology. So there's a 24-hour help desk on the other side that is always ensuring that all the processes involved in ordering and making sure that the goods ordered are delivered on time are assisted with staff that are there. There's also a quality control mechanism, which I will explain sooner. Documentations are there, and there's a dedicated website that I will demonstrate very soon. On the extreme right, I've spoken of finance mechanism, and there is also, of course, capacity building interventions. Training programs are always ongoing on that level. And we have standard operating procedures to aid the interface, the interaction between suppliers and healthcare providers that are participating in this. And consciously, there is an aspect in between the light blue bar, in between onboarding. Onboarding is about enrolling service providers and suppliers in the Med for All. It is just not a prescriptive policy, but we believe strongly that issues of procurement ought to be merit-based. You have to encourage, you have to come out with policy, you also come out with nuanced ways and means of getting people on board. So that is a very vital aspect of it. So let me show you a sample screen. Sorry. Yeah, so, sorry on that. I'll be showing you a sample screen of how the process pans out. No, the other one, please. Yes, this particular one. So there's a sample screen. Probably we're having challenge getting it. Yeah. So there's a sample screen that ensures that once you click on, you place the order, it goes straight to an app, and the participating suppliers, like NS Chemist, Kena Pharma, without advertising for anybody, these are accredited partners, they receive the orders, and within 7 to 14 days, they are required to deliver. And then in a spirit of reciprocity and mutuality, the ordering service provider is also required to pay within 30 to 90 days. Now, the 30 days, 45 days, and 90 days are incentivized, meaning that should you be able to pay in 30 days, there are inherent incentives to make sure that, of course, the 30% may even go higher to 40% that are there. And so such mechanisms are there. And thus far, participating providers are actively involved, and we are seeing evidence of it. So with all these features and high-level technological solutions to supply chain, what have been the specific benefits? One is that there's now a common language or standards that have been established between service providers and suppliers. By the SOPs, standard operating procedures that have been availed for all parties, we speak one language of digital supply chain mechanisms that are well understood. And then, of course, we have ready access to data. Data is very necessary. We had some stock out, not necessarily because of delayed payment and inability to pay. Some facilities did not even have an idea of inventory management and how to plan properly. And definitely, we have data from all sides. Service providers are able to place order on time, and suppliers are also predictably able to plan their production to meet orders that are also given. And of course, liquidity is very vital. Suppliers are always crying. So if you are able to guarantee payment within 30 to 45 to 90 days, it also enhances the business case for suppliers to be on board, to really make certain concessions. So with a short period for payment, suppliers are so naturally excited. And stockouts have reduced significantly. It was always a challenge when patients had to come to hospitals, and then they are handed out, after all the diagnostic processes and procedures, they are handed out with prescription to go out and source medicines outside. So naturally the risk, the high cost out-of-pocket payment, and even quality that cannot be guaranteed are issues that that this Med for All program is helping to really cover. It is also helping in many ways on out-of-pocket payment without necessarily making any admission. It is a worry that the Honorable Minister of Health has been concerned about, and I can see the CEO of NHIS nodding. The Med for All is helping significantly with reduced prices of medicines. Naturally, most of these medicines have become affordable for providers, and providers have had to really appreciate that and transcend the benefit to clients. And of course, with inventory now better managed, patients will not have to go out and source medicine from outside at exorbitant prices that are there. Inventory management has been better enhanced. There's a whole app that I'll demonstrate very soon on this. The app could not even appear properly, but in the app, it has inherent spectrophotometric devices that is able to, that's called TrueScan. I will show very soon on the TrueScan. And so quality has been better improved, and the stock taking app is helping to identify quality medicines, fake substandard ones that are there. And when you digitize processes, it enhances transparency and accountability. Now, the human interface is reduced. More people are involved in real time. There is a monitoring, and so naturally, transparency, which is a core value of CHAG, transparency, accountability, have been enhanced by this Med for All application, and we believe that it is cascading down at all levels. Quality, as I mentioned, is being enhanced. Quality cannot be traded, and quality is a key determinant on how far any healthcare system can impact patients. And so quality medicines are being guaranteed through a TrueScan with spectrophotometric device. And it is an authentication system. And it is really on the right side, you find this handheld device that is called Raman Analyzer. It uses laser-guided spectroscopy. And just by shooting it to the tablet, either tablet or suspension, it is able to identify some active ingredients in the medicine. And it is able to then come out with terminal assessment to indicate whether the medicine that is being provided has passed or failed. This particular device, as small as it is extremely expensive, and probably in the entire country, I'm sure apart from FDA, this Med for All program is the only one of a kind with having access. You didn't get to know that. You didn't, otherwise you would have clapped seriously on this particular intervention. No running costs. Once you obtain it, we obtain it, and so we use it to validate, authenticate all the medicines that are supplied. No reagents, solutions needed. Minimal training. You just point it and shoot, and it works. With terminal assessment on whether the medicines that are being dispensed or supplied at our end pass the terminal test of either pass or failure, having the necessary active ingredients. And most importantly, it is local and international compliant. The Food and Drugs Board, the FDA, European and US pharmacopoeia have certified is compliant to international standards. So it is not something of a new, it is compliant with all the relevant international standards you can contemplate. And that is a key quality feature. There can never be any other guarantee of medicine within the system than this, a mechanism that validates authenticate medicines in real time. The stock taking up is also very exciting. It's a digital solution, and that is able to recognize by scanning barcode and reading text and the rest, it's able to identify the number, aid inventory management within the system, check which medicines are there, which medicines are out, and that is exciting. And much more, it is feasible to use it in any part of the country, be they Salaga, my hometown, Doma, and any other place. It works offline and online, and that is a vital feature of it. And it is able to aid in coming out with the consumption pattern, data in real time, and that helps with forecasting, purchasing and supply in real time. And data is very necessary. And as I've mentioned, once you have the data, it is able to inform appropriate decisions as far as procurement of medicines are concerned. What are some of the challenges? Low volume deliveries, that makes it very difficult. Most of the suppliers complain, and that is a legitimate complaint. If you are supplying goods worth barely 2,000 in the remotest part, Boko, naturally it's not worth it. It is high cost. And so the essence of digitizing is to improve process efficiency and to reduce costs. And so we are having challenges with low volume, but there are prospects that I'll highlight very soon. Long distance are not really helping. And there's what are called perverse behavioral economics. Procurement economy has a lot of unethical issues. So when you digitize and you remove the human interface and it's 100% transparent, your guess is as good as mine. Naturally, you're having perverse behavioral economics. People would like to equalize their income, whatever it is. So you have hesitancy. I didn't say vaccine hesitancy. This is procurement hesitancy of a way. And we are curing that malaise, not only prayer, but by active onboarding engagement. One other challenge is interoperability. There are several diverse supply chain systems in the country. How do we harmonize these? So interoperability is an issue. Integrating all the diverse, procurement or supply chain software is an issue. But diversity should be a strength. We want to see how we can harmonize. And CHAG is made up of 34 denominational groupings. As I said, we onboard by policy and by active engagement. You have diverse being an initiative. We are norming and forming. So you have some of our constituent members that are already used to some past manual type of processing. That is an issue, internal issue we are addressing. But it is not all doom and gloom. Certainly, there are prospects and potentials with this Made for All program. So far, the benefits that have been documented and evaluated, I'll call it formative evaluation, have shown proof of concept. There's a template for scalability. So moving forward, we want to scale it up to all CHAG facilities and even having a way of onboarding private sectors. It is not only a CHAG PharmAccess program. We were piloting it, and the pilot phase has gone ahead, and it's very clear that there are several benefits that could strengthen our entire health system. And certainly, moving forward, we believe strongly that if universal health coverage is to be attained, harnessing the power of technology or digital solutions to enable and accelerate progress towards universal health coverage is very vital. CHAG has shown the way, and in the years ahead, or in the times ahead, we are going to actively scale up, engage actors, so that the Med for All Plus program that improves the three key elements of any supply chain system, access, quality, and affordability, will be enhanced. God bless you for listening. Amen.
Thank you very much indeed. A big round of applause for him for me. That's Dr. Peter Yeboah. He's Executive Director of the Christian Health Association of Ghana. We're going to take a quick 5-minute snack break. When we return, we'll hear from the chairperson, who, of course, had to take leave of us. And so we'll hear from him very briefly. And then we'll continue with the conversation. But I wanted to take note that I know that a few of you may have questions to ask of some of our guests who have spoken already. And so there'll be time for that very briefly to happen. Remember that we are live on the Joy News channel. We're also live on our many social media platforms, and there are many of you who joined us via Zoom and through the power of technology. Wherever you are this morning, thank you for staying with us. We're taking a quick 5 minutes break for snacks. We'll be right back to continue with the conversation around digital health. Stay with us.
My name is Isaac Komsen. The book is for the Mikusun Juma, the year 2010. Say a Jumano. Ewa hanum na ye ya almost omo nkofa ibi free outside takwa na omo mama me yede na he nka like to see bia na with lorry fair na say so omo free nipa no from outside takwa obeba oba be ye adwuma no nti so the way so omo timi so nya ye ho benefit ese me nya nkofo no bi ye nam discuss ya oye pe ideas are there be se me dem omo say mine say adwuma enye the only kind of worker a war takwa community yenyina we jibitima eden yenya we jibitima nya bia ye nti no omuntimi occupy sa boys ni nyina we da e was sa man isi ni nti no wo so wo wonsa no adwuma ono ane se wo be ye no eden wa ye ni madwuma no in vision I woman so say we pe say adwuma no be ye kese like it drew as company form. And the person that we say a lot of boys are train your mom so meeting my baby to say me no visions I then
People before power. We're about the people, not the powerful. Joy News. Independent. Fearless. Credible.
If you're looking for someone who is very entrepreneurial, then it's got to be Harrison Mati.
I've been into bicycle rental. I've been a shoemaker before. I've been a farmer. I've tried fashion a bit. I actually thought of modeling at a point. I know I discouraged myself from doing it because I couldn't make time for rehearsal. And I've tried a few things. I've tried a few projects here and there in fisheries and then in solar. And I can say I've failed in a few or in a lot, and I've learned a lot of lessons from them as well.
It was what he learned from his mom's chop bar that would make him interested in starting a restaurant. This Wednesday on the Joy Business Fan, on TV, radio, online, and on ground. It is powered by Joy Business and supported by Ecobank, the Pan-African Bank, and MTN. Everywhere you go.
Alexa, Open Multimedia Ghana and play Joy FM.
Super Hits Radio. Joy 99.7.
Listen to Joy FM, Hits FM, Love FM, live on your Amazon Echo. Listen to your favorite multimedia radio stations live on your Amazon Echo device by saying, Alexa, open Multimedia Ghana, play Joy FM or Hits FM or Love FM. Or catch up on your favorite podcast by saying, Alexa, play, and then the name of your favorite podcast from Multimedia Ghana. For a list of all podcasts available, say Alexa. Ask Multimedia Ghana to browse programs. Alexa, welcome to Multimedia.
Welcome to another insightful installment of Drive Safe, where we learn how to drive safe, what to do on our roads, what not to do on our roads, so that all of us can prevent the carnage and stay alive, basically. Now, we're going to continue from where we left off the last time. But right before we get into today's installment, though, so you think you know. How much do you know about road signs? Well, look at this road sign and let's find out just how much you know. Now, at the tail end of today's segment, we're going to give you the correct answer, and you'll find out just how much you do know.
Right, so let me start it this way. A lot of us have been using parking lights to drive. It is so wrong. You don't drive with parking lights. Parking lights are made for parking purposes, and the law says that if you park your vehicle in an unlit area, then you can use your parking lights for other road users to know that I have parked my vehicle and therefore I am not moving. Parking lights are so small. And the law again says that from dusk to dawn, your lights must be on, and it is talking about your headlights. Right. Now, in other countries, we have what we call the DTRL, daytime running lights, okay? Which means that when you start your vehicle, your lights will come on. Now, these are vehicles that are coming from, let's say, the United States and even Europe now, where you have weather challenges, where weather can change at any time. Okay, so we have a DTRL, it's a daytime running light. You start your vehicle, your lights are on. When it comes to Ghana, the commercial drivers, get to see the electrician to say that there's a problem with their lights. When they start the vehicle, it is on. But no, that is automatic. We must leave it. Now, the daytime running lights are even lower than that of the dim lights that we see. And so you can drive with it. That would not blindfold anybody on the road. And it is good if we all have it, because the law again is saying that we must see and others must see us. For instance, if you have the DTRL fixed on your vehicle and then you are traveling somewhere around the Ibri Hills in the evening, in the morning,
and all of that.
Right, it's easy, okay, to drive through the fog, and sometimes it's even it's even so difficult for others to see that there's a vehicle coming. So that's the purpose of the DTRL. Okay. But then again, I said no extra lights must be fixed. So those who have fixed all those extra lights must be clamped down. They must
You're talking
be
about extra lights. How many lights, basically, on the frontage of a car, from the side to the front? How many lights maximum should we have?
So you have the headlights made up of the dim, which is a pair of dim, and then you have the highlights, which is also different, a pair of highlights. So you have two left, two right, okay? But when you switch on one, which is the dim lights, okay, two of the lights will come on. And then you have the fog lights. So we have four. We have the fog lights for other vehicles, okay? And the fog lights doesn't throw up. It throws down below and then your sides, okay? In other cases, you can even see the whole side of your vehicle. And that is okay. That says the law. The type of lights that you're using is what I mentioned. It's either the halogen lights, and it's being calculated. Some are 60 watts, okay?
And I mean, that's the maximum. You can't go for 100 watts bulb. Now, those 100 watts bulbs are used in showrooms, and it doesn't come out.
Right. So are there differences here when it comes to the countries as well? You know, the road regulations differ slightly, though there's an international convention, if you like, but they differ slightly. So, for example, like you were saying, when it comes to other components and what may apply in the EU and all of that, are there any differences here when it comes to the wattage of these lamps, and maybe when they come into our country, our jurisdiction, are there any things that people should be doing, or we should just leave them as they are?
Leave the vehicle as it is by the manufacturer's specifications. Now, in the showroom where they want to display maybe a vehicle for you to purchase, right? They have maybe 100 watts to see for you to see, that this vehicle has this lights and so on. But we call them showroom lights, and they are not meant for driving. And that is why when you go to a place
so it
like...
means when you purchase the vehicles, these are taken off?
Yes, these are taken off. If you are purchasing a vehicle, it runs through a whole complete regulatory system. I am quite interested in that, because you see big trucks in the country, and then they have fixed almost 10 lights, especially when they are traveling on the highway, right? That is not allowed.
Let's talk about the lights. You mentioned, is it HDI? So
Yes.
let's look at the three different lights, and we'll be illustrating for our viewers and how exactly they show on a road.
Okay, so I'll start with the normal lights that you see, which is, a bulb sort of light, okay? And then you come to the second one, which is xenon, okay? And then the most powerful one, which is the very latest, which is the LED, okay? And then...
those are the ones that through a very high, whitish beam.
Yes, they are white. When you put on the LED, it's just so, interesting. It comes slowly before it lights up, very powerful. But again, all have been calculated for the usage of the road, that if you are using it, it must not, hurt anybody's eye.
Okay.
So people get so confused in terms of whether I should use a yellow light or a white light.
That too. What should we be using?
There is nothing wrong with it. It should conform with the regulations. Your lights could be yellow or white. There's nothing wrong with that. Okay. But you must not fix one yellow and one white. If you fix the lights and they are yellow, all must be yellow.
Uniformity.
Precisely, uniformity. You go to the Francophone countries, you cannot use white lights there. Their regulation is different. Use yellow lights. But in Ghana, we can go for the two, either white lights or yellow lights.
Today we've been learning about headlights. We've learned, for example, that you can use white lights throughout or yellow lights throughout, but you can't mix them. But right before we wrap, so you think you know? Well, this is the road signal or the road sign that we showed you earlier. Do you think you know what it was? This actually is the answer. And so there you have it. This is another installment of Drive Safe with me, Benjamin Akapo. I have been with CEO of Top Tech Transport and Logistics, Mr. Cecil Gabra, who's been gracious enough to have us come here and be with him. Don't forget to drive safe and stay alive. Thank you for watching.
Thank you so much, Evans. I'm sure that the few hours or few minutes of presentation by Dr. Yeboah and Baba Selby is something that is revealing. And I'm sure participants here would agree with me that from their perspective, they've been able to share with us the enormous benefits of digital health in their respective sectors. If you look at the area of health insurance authority, the benefit has been both sides. The perspective of the regulator or the authority, and then also from the angle of the consumer. Now, in Barbara's presentation, you would find that the user rate, or the user rate has increased, those who are subscribing. It could be a case that easy accessibility has encouraged has boosted up consumer confidence. And for that matter, all those who were quiet and latent have seen the need to rekindle their interest and to overwhelmingly subscribe. There again, it would lead to some sort of revenue gains by the insurance authority. Now, the insurance authority, as I stand here as the chairman of the Health Select Committee, by virtue of our interactions with them all the time, we have seen that the introduction of mobile health usage has reduced expenses in the area of printing cards, printer breakdowns, and all of them. And then they can also say that they have even increased a certain revenue. That was to do with the renewals and the premiums. That was usually hovering around the 60, 50, 70, and suddenly with this mobile app introduction, we are around the 150 millions. Although they are yet to give us clear evidence on the contributing factors, it cannot be just sudden that for a period of which longitudinally you have seen things around 40, 50, 60, and suddenly with the introduction of the mobile application for renewals, it goes to about 150, and you cannot say there's some sort of association with it. There is, regardless of whether there's a publication to it or not. And so, we can see that leakages can be blocked, consumer confidence can be there, more enrollment, access is easy, and all of you, and all of it. Now, from the perspective of the patient or the consumer, if I had to leave Tetekaso in Efijase or a certain village called Kwankwenia, that is so long stretch to the capital, and I will have to pay about 10 Ghana cedis. The 10 Ghana cedis, roughly about $2 or maybe $1.5. That is not really a big deal to somebody maybe in the city. In my kind of world there, 10 Ghana cedis is a big deal. And for that matter, just renewal has encouraged that sort of confidence and the knowledge in the process. And you can imagine the way they will also sell it to other people to have that interest, that, hey, now it is available, you can do it this way, and people will want to subscribe. So yes, it has saved consumers some money. Transport and waiting times. When you go to where they renew cards, previously, it's a lot of them, when we go on parliamentary monitoring, we are not happy. They'll be sitting there a lot. Some are fighting, have been here since morning, and really much just this introduction has changed it. So I think in future, Senior Maxwell, the perspective of the patient, and if there are NGOs here who are actually going to speak for the perspective of patients should be speaking for themselves. Far and near, to share practical experience of the usage of digital technology in assessing healthcare. And that would mean that not only the providers or the regulators will be speaking about what they are saving, but the perspective of those who are enjoying it is very crucial. Now we go to the area of presentation by Dr. Yeboah, my senior plenipotentiary. He cataloged the gains. The Met for All program, the interface, is saved about 20 to 30% on expenditure. He cataloged that if we can indeed get quality and affordable healthcare, clearly, these interventions is very important. And you see, He is next to the Ghana Health Service in terms of providership, strength, and user enrollment from the rural areas. And when he speaks, he's speaking from very marginalized society to a middle level. And if indeed these are some of the returns that he's getting by the introduction of digital health, then there is more that we need to together come on board to be able to assess and to make it available. Now, HeFRA has not presented, but like I said, I am the chairman of the health committee, so I have privileged information. I know for sure that with the mobile online information system, which was pushed by Dr. Bano, maybe Dr. Bano has experience working in the US and he's used all this, so therefore he has a strong passion for the use of digital health in the health sector, digital consumption in the health sector. Indeed, there has been an increase in revenues, and they have actually collected what usually they would have done an efficiency rate or performance rate of about 40%. Now they are doing about 96% in about 8 months. So, I think that this is the way to go. We need such fora that brings stakeholders together, that even put pressure to bear on the system, the government. Responsibly, the provision of infrastructure. Because if somebody will be comfortable to use this in the most deprived area in my constituency, Adukrom, then it is based upon the infrastructure that the system will put down for us. Whether it's broadband, whether it's mobile, whether it's internet, whatever it is. And this is where I think that we need to support government to get the e-levy through. I mean, indeed. You see, we are moving into the age. And this is going to rake in about, let's say, 5 or 6 billion cedis a year as captured in the budget. You see, the point is that there's a thin line between health and finance, economy. Am I right? There's a thin line. Because if the health system don't do well, if the economy is not doing well, it affects the health sector, and vice versa. Even on quality of health. Countries that have high GDP and have high good healthcare systems, longevity and everything is a change of life. So there's a WHO publication that shows that there's a link between the quality of life and the GDP or the economic resources available. So we would need more resources. And because we will need more resources to be applied in the area of digital healthcare, so do I also agree that there must be digital taxation. And at this point, since I'm the chairman, I think I can veer off without being restricted, just for a minute or two. Because the process is ongoing, and we are taking advantage of what is ahead to be in our sector to make progress. So if the resources are going to be allocated efficiently, and there will be technical efficiency in the allocation of resources for the consumer to have returns, then this is where we'll be interested in what the government should have. Because if they have 6 billion in pandemic, you see, the other thing is that COVID, disguised, we are not comfortable with it, but it is putting that pressure for us to consume digital-wise rapidly. Now, the paradox is that COVID is also affecting your economy. And in the advanced societies, where they can do what we call quantitative easing, they can print money in the US to push money in the system. If you are not working, take this money. 1.8 trillion they are printing. Because their system has industries that produce. They print the money, it balances. But for you, when you go and print money, there's going to be what we call demand pull inflation. As soon as you print, they will have to go and import. They will change money on the forex. Your city will start falling. The one who will bring it will put it on the cost of goods. And then everything will start going on the high. So we don't have a luxury to print. And then also you go to a place where you have what we call GDP. That assesses your strength of your production. If it's a company, how much you produce and how much you are worth. And they assess your debts to a GDP, and we are around 70%, 71% without bailouts. And with bailouts, those financial clearance in the economy, financial sector, energy, or whatever, blah, 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 it goes to 77%. So we can't borrow to finance health. So as we talk, I'm talking about the financing. So we cannot borrow within, if it is with bailout, we are around 77%, 77 on 100. So we can't borrow. So the only way we have to go is to tax a little. Ghana's tax to GDP is around 12.2%. However, if you go to the global society now of digitization, 10 countries have subscribed in the Africa Tax Administrators Forum to be able to make taxation on digital health so that they can apply it to where it deserves, to improve content, infrastructure. So we cannot be able to talk digital health or digitalization of the health sector without improving content and also infrastructure. And all those who are here, provider interest or groups who are interested, if there is no infrastructure, then we will count on people's aid. What the US is doing, what Norway is doing, what this agency will doing to help you. But the point is, what can you do for yourself? And that is where we cannot live without looking at what resources, because there are 6 pillars of health systems. Healthcare financing is there. Health management information systems is there, through which we are talking about all this ICT. So if you want to have strong health systems, then healthcare financing is there. Then you should look at where the economy gets better. And then this can also then get better. So in India, they introduced 2% digital taxation in February. In France, they're introducing it this December. In Russia, before pandemic, they are doing 8% on digital taxation. In Indonesia, they are doing 10% since January on digital taxes. Now in Tanzania, they are also introducing same 2 months ago. If you go to Kenya, their tax to GDP is about 15.9%. Ghana is 12%. And they are also going to introduce digital taxation. So vice versa, you cannot make progress of consumption without looking at the infrastructure. And we cannot pick our caps in hand to go to all these donor partners to go and beg all the time. You are begging for them to be able to support your own infrastructure through their taxes. So for me, I think this forum is very good. In as much as we talk about the various effects and the benefits, so should we also look at how do we get financed? I would have loved that the system would take a next debate where the e-levy goes into an e-fund. What the Minister of Finance has proposed, e-levy will go to support budget, blah, blah, blah. Yes, that's it. But I stand here as a provider of healthcare and as a citizen of Ghana who think also that if there's also debate into, let it be a fund. Let us know that this amount of money goes into health ICT, this ICT content provision, so that you can see how much is there for digital development. Otherwise, we'll make a lot of noise, you pass the budget, and it goes into budget support. Yes, and it will go through. So you work, you do your talk, we do our work. And yet, the civil society is supposed to provide the vigilance that it deserves. Can there be some way to be able to look at the resources and then do stakeholder participation so that that amount of money that gets from digital taxes will have to be in the fund, and X amount should go into this development so we can make progress. So on this call, I would say that we are on a good trajectory with regards to the presentations and seeing the benefits even at the very little, at the smaller stages. We are not there. We are at growing stages, but we are seeing the little benefits of improvising or innovating the healthcare sector with digital consumption. the future is bright. And I'm so proud to have been part of the deliberations today. I wish the best for all those who are presenting thereafter, because I have to leave for Parliament, and we will look forward to what comes out of it. Thank you very much. Thank you very much.
Thank you very much. A big round of applause for the Honorable Minister. Yeah, I mean, he said a lot of things that definitely food for thought there to chew on. The suggestion that the e-levy should be put, the funds from accruing from there should be put into a digital fund. It's an interesting one. Thankfully, he's heading to Parliament. That will be debated and see if compromises are going to be made. Let's see. Thank you very much again, the chairman of the Health Committee in Parliament, Dr. Nana HeFRA. So, ladies and gentlemen, we'll continue our conversations around digital health. And I want to invite a gentleman who is an internal medicine specialist by profession, has been practicing internal medicine since 2001, graduate of the Medical College of Wisconsin in 1997, received medical training in Milwaukee and also with the General Hospital Nashville, or in the USA, by the way. He was board certified by the American Board of Internal Medicines in 2002, holds an active medical license in the United States and Ghana, member in good standing for very important, powerful associations, the Ghana Medical Association, the Tennessee Medical Association, and the American Medical Association as well. Now, until his recent appointment, he was a director of electronic claims, and so you begin to appreciate his background and relevance to this conversation at the National Health Insurance Authority. So he's been there, he's done that. He was charged of processing the center, the claims process, electronic processing center at the head office in Accra, and also had done some interesting publications also, including infection prevention and control in healthcare facilities during the COVID-19 pandemic in Ghana. So this is very recent. Ladies and gentlemen, with a round of applause, please help me welcome Dr. Philip Bano. He's the registrar of the Health Facilities Regulatory Agency, HeFRA. We've heard a lot about them already, and I'm delighted to hear a bit more from Dr. Bano. Dr. Bano, thank you very much.
We have the presentation ready. Thank you, moderator. And I have to say, the chairman has just left. So the country director of PharmAccess, Dr. Maswalenchi, the CEO of NHIS, Dr. Selby, the CEO of CHAG, Dr. Peter Yeboah, CEO of Health Federations of Ghana, Dr. Decker, all the invited dignitaries, ladies and gentlemen, friends of the media. I hope I haven't left anyone, so I was standing on all other protocols. I'm excited to have received the invitation from PharmAccess to be part of the Digital Health Week, which is to highlight the national efforts for universal health coverage, the UHC. Presentation. Oh, yes, okay, very good. It's going to be in a presentation mode, so you can look pretty much what is here, just like the others have done, and then we'll take it from there. That is me. You can move forward. Oh, okay, I need to operate it from here. This is a presentation outline. The slides look busy, but I'll be brief and then take you all through it. So the background of HeFRA, and then functions and objectives, our vision and mission, digitization needs assessment, digitization policy, key strategies required for the digitization Then key activities. And then I'll try and focus here. Okay. The functions of our mobile online information system, which is what we call our online process or system. Then other digitization process we have at HeFRA. I will be brief there. Then, as others have indicated, the benefits of the digitization, and then obviously the challenges and the way forward. Some of the background information about HeFRA. Is one of the acts that was passed right at 1958. I don't want to go so much into history, but it tells you that health policy, health regulation was quite foremost on the minds of the founders of the nation. I believe it was Act number 8. So it tells you how a prominent health regulation meant to them. But with the benefit of hindsight, I can criticize them because the act they passed was Private Hospitals and Maternities Homes Board. And obviously you see an issue with that, don't you? Private hospitals and maternities home board. I don't think they recognize how much the public sector was going to grow. And then for many, many years after that, they have to come back in 2011 before it occurred that no, we think we've made a mistake here and we need to go back and make sure that the public sector also has a regulator because that field was unregulated. And in fact, that is where most of the growth occurred or was occurring at that time. So with that, they formed the Act 829, which says that an agency will be called this HeFRA, which is the Health Facilities Regulatory Agency. We are an agency, not an authority, and there's a difference. Will regulate all public and private health facilities for the provision of healthcare services in Ghana. It is simple enough, isn't it? All private and public. I said for emphasis here because there are some entities out there who believe that they are excluded or somehow they are not part of the HeFRA's regulation. I say that with a bit of humility here, and I keep reminding people, if you are in the service of healthcare provision, the chances are you need to take a look at the HeFRA's Act. There are so many ways. I don't want to throw my weight around, but I can come after you so many different ways, honestly. So those that believe that they are somehow exempted, I'm not so sure if you're so exempted. Ambulance, for example. The moment you place a patient in ambulance, that place becomes a facility because ambulance is listed as a healthcare facility. I had to explain that to someone. Forgive me for saying that. But be very careful, okay? Sometimes when I read the thing, I am a bit excited, and at the same time, I'm humbled by the breadth and the depth of the act itself. So if we are providing health care, the chances are you come under HeFRA's Act. And I will say more as I keep on going. There are over 30,000 healthcare facilities in the nation. That's an estimate. So it gives an idea what the enormity of the issue here. Okay, what are the functions that are placed upon us to do in the Act? And I'm just picking just a few. That we must register all health institutions. And our registration is not just collection of data. Or you just fill a form and you give it to us. We need to verify the data. So when you give us information to us, the first thing we do, go to Registrar General's department. Are you a registered entity or not? Then we must look at the people that you have listed in the document itself. We go to Medical and Dental Council, National Midwifery, Pharmacy Council, Allied Health. Government collects data on every graduate into the profession. Are you there? In a healthcare profession, government collects data and maintains a registry. There's a data registry for everyone, including those who are in good standing and those who are not. So this is all part of the registration, okay? And I think you understand. I don't need to explain why we need to check with that, right? To make sure there are no quacks in the system. And then it says that we must physically come in and inspect the premises so that whatever care that you have stated in your application that you want to provide, your physical layout is fit for purpose. So I used to say that there's a different, one way to look at HeFRA is look at a triangle. The top there will be persons or personnel or professionalism. The two ends will be infrastructure. Then the other end will be equipment. Okay, so people, infrastructure, equipment. That completes the triangle. Then we must, if you pass, we must license you. And then we are required to continually monitor you, either from 6 months to a year or 3 years, depending on what we find. Our vision is to be the continental leader in healthcare regulation. When I took this job, I thought Ghana we have a lot. And then when I began to study other nations in Africa, we are good, but others are ahead of us, South Africa being one, and others, Egypt, and so on and so forth. But our vision is to be the continental leader. Our mission is to make sure that our facilities that we regulate deliver the safest and the best quality of care to their clients. Digitization needs an assessment for the agency. Let me begin by saying why there is the need for digitization. I've mentioned that we have over 30,000 healthcare facilities. That's an estimate. So nobody even knew how many we have out there, but we needed to do that. Now imagine all these facilities doing a manual system are all coming to Accra to register or to do business with us, or go to the regional office also to do some of the transactions. They can't do everything at the regional office. Look at the travel time involved. If anyone is in the northern sector of the nation, like Kumasi and beyond, usually it's more than a couple of days. By the time they get to Accra, the time they spend at the office, by the time they get down, the time they're going back. Then we find out that after we introduce the digitization, the average facility within 3 to 6 months needs to update a critical component of the information they provided. So it means that all those who are doing it manually, it looks like every 3 to 6 months you have to come back and update something. Either the provider in charge, what we call the PIC, or the doctor or the pharmacist, if it's a pharmacy, or the head of a department, if you're a hospital. If you're head of department of surgery, for example, or pediatrics, internal medicine, ops and gyne, that is a major key person. If that person changes job, moves, you need to inform HeFRA. Not that I want to chase you, but because we need to know the person that you are hiring can head or do that job. Are you with me? Let me digress a bit. Let's say we credential you that you are a referral hospital. A referral starts from regional hospital. That's an easy way to remember. You must have not fewer than 10 specialty care delivery. Often ends up being about 14 or 15. Specialty care delivery must be provided by who? Specialists, right? So that is the reason why you need to update us that information. And if the person in charge moves, you actually have less than 60 days. The in-charge person is a very, very critical person that should be left unaddressed. In fact, technically, if the in-charge person, upon whose name the service, the license is issued, if that person were to leave, technically the license is withdrawn on that day. So we also impress upon those who are the in-charge person that if you are going to leave a facility, in fairness to those who hired you, you must give them 60-day notice so that it does not cause disruptions in care, okay? Then there was issue of uniformity of standards. Because so many of these standards were written all over on the manual, some of the interpretation and the application of these standards were not uniform across. And last but not the least, financial mobilization, which I'll get into it a bit later on. So these were some of the issues that necessitated the need to move from a manual to a digital platform. So we had some. Now, when I came on board, there were already discussions to digitize HeFRA, but conversations and a lot of moving parts and a lot of challenges, and things were a bit stalled. There were obviously delay in operational activities because simply things were manual process. I remember when I joined, we went to license, inspect an important facility. Then only to find out when we came back that the team had used not the right type of assessment standards. You see that? But if they had a digital process, this could have been avoided, because someone is going from a primary to a referral hospital, or from a referral hospital to a tertiary, which is a teaching hospital. The quantum of requirements will change. And if you put that application in there, it will pull all the standards for you and avoid some of those things. So they had to go back and apply the right standards to that hospital. And it's working now. So this is one of the things that digitization can avoid. Clients have to travel. I've already said that. Digitization hopefully will make us more efficient and more effective. The policy, I tell them to delete the entire policy. I think it's not necessary. But I'll emphasize the second point here. To bring our services closer to the clients through digitization to ensure efficiency and effectiveness. That is essentially what is driving our digitization policy. Now, the key strategies required for our digitization policies are the following. Now, we want to build a robust IT infrastructure. That's needless to go any further, right? You cannot have digitization if you don't have an effective backbone, and that is the infrastructure, the hardware, and also the software system. Question like this will take close to 2 weeks to negotiate with all the providers. But finally we did. So all these things are written down. Okay? How many nurses, how many doctors, how many pharmacists, how many... Now we are saying that if you want to be a hospital, you must have even a biomedical engineer. Because so many of the systems that you are using now require it has some sort of software in them, even blood pressure machines, right? And some of the monitors, they must be inputted so they can be displayed, right? Sometimes we hire and they say, I don't know how to operate this. So now we are even saying, hey, maybe as you advance, you may actually need a hospital engineer. And so that is now going to become a new, and I have to impress upon them. So a lot of requirement, professionals and things are needed, okay? And then, so this must be digitized and incorporate into a scoring system. You are seeing how difficult the process is. And I'm happy to say that that one is ongoing this week. On Thursday, with the help of PharmAccess, UNDP, and UNICEF, I'm making an announcement ahead of myself. On Thursday, we are going to validate. The stakeholders are going to come in on Thursday, and we are going to validate that system. And then we are going to move on with that. That is a different system, and I'll come back to that. Then provide an online payment system. I'll come back to this. Then, I think Dr. Selby or Dr. Peter Yeboah mentioned this. We can't work in silos because, as I said, we depend on other state agencies for input. Are you with me? So Medical and Dental Council they have done quite well, and I have to commend them in providing data in a bit of a digitized form. So we can then incorporate, are you there, or integrate the data. I wish I can say that with all the other regulators, okay, but they also need to digitize so that input of data is also possible. So we have to have integrated data. And that would also help the ministry to actually know who we have in real time. Then you can get a dashboard and so on and so forth. So this integration process is very, very key with other state agencies. So that we know, if I want to know how many chips that are registered on NHIS, I should be able to get that data. And NHIS, too, I'm sorry, it's also digitized, as you already know, and we can get data there on tap, and we share data with them frequently. So that was on. Now, development and deployment of appropriate software for the operational activities of the online payment system. Now, this began, we signed a contract last year in March. Now, I have to say, finding a software developer and things, HeFRA, we did it all by ourselves. HeFRA, we did it all by ourselves. Oh, can't you do better than that? I appreciate that. It's quite an expensive thing to do, but we managed to go through the procurement process, and then finally we found a developer that is willing to work with us, and we are paying the developer to do that. So that's the vertebra whom we landed on. Continuous engagement with the provider, so that if there's any problem anyone encounters, give us a feedback. There's a way to send to the registrar. It says registrar, but it goes to the head of IT. We have weekly or bi-weekly meetings, and we share with them so that they improve the system. We began the deployment in March of 2021. So it's about a year from the signing to when we could start. And all of that was to, it went through quite a bit of testing ourselves at the operational level before we could start this. So that is what the minister launched for us. HeFRA goes digital. If you've been in the booth, you saw that, right? HeFRA goes, that's what the minister launched for us. Very good. So ours is not as long as NHIA. Therefore, our achievements are a bit modest. Nonetheless, they are on the same par as others who have been on this digitization a bit longer than what we have. So we're talking about 7-8 months. But I think we have a story to share, which the minister has already taken my punchline, but I'll repeat it anyway. So what must the system do? So it has a registration module, which is mainly your submission. So we can receive application, which means that if you are a provider of any kind, you can go there and initiate. You are the facility manager. That's what he said. Whenever you are starting, it assumes that you are a manager or owner or someone with the executive ability to register on behalf of that facility. So we go for facility manager, and then we will receive your application on our end. The good thing about this is I just talked about 3 to 6 months, the average facility has to update. You can upload all documents there. I know there's a challenge. There's a limit so far about how much data or gigabyte you can, but it is improving. The developer is adding more and more. And HeFRA, we are going to get our own internal servers as a backup. And as we increase the capacity, you can load more. But you can load quite a bit of information there. Again, you don't have to mail it, put an EMS or drive or walk to any. You can do it there, okay? Then you can save. You can hit complete, which means submission, upload more data, and then you can go back. If you are not ready to submit, it's best to save it. This was a challenge initially, but we've resolved that problem. Some people thought they were saving, so they hit complete, and then when you hit complete, it submits. So if you are not done, just say I'm saved. And then you can come back to where you are, and then you continue. Then when you are done, there are 2 things that must happen on our end, which is that registration head must look through all the data, make sure it's complete. Of course, there will be a little payment there, so the finance people also make sure that you've made the payment. And so a couple of things, and then either I or head of operation has to approve it before it moves on. And then you get an email to pick your own date for inspection. How convenient, okay? So you tell us when. We don't want to come, then you are not ready. So you pick it for them. And then those who come now can prepare the reports. When we finish the validation we are going to do on Thursday, even the report, actually, we can even do that now. They can upload the report onto the system. So you can read your own report and the score you got, even today, because I've seen some of them. But when we do the validation, it's going to be more enhanced. Do we have the, I think? Okay. Licensing module, verification and renewal system. Generate and renew your own license. Receive notifications from us 6 months before expiry. Every month to get in a notification. Provide renewal application profiles and so on and so forth. Monitoring schedule. Oh, what did I do? Okay. Monitoring is based on your score and where you ended up. We say 6 months, we are coming back. And you would know based on your score. And you will get a provisional license and a letter that will tell you why you are provisional. okay? And then those who pass will get 3 years, okay? That's all the law. So you will know when we are coming. Mandatory, let's move on. I was ahead of myself. Status of registration. So you can see there, oh, my application has been approved at registration. You can actually follow it. It's at the inspection, licensing stage. And soon, at the licensing stage, actually, I was informed yesterday, but I was going to make a bit of an announcement. But my IT people said, registrar, not quite yet. I'm looking forward, maybe within the next week or two, you can actually print a copy of your own license. Are there any healthcare providers here? Usually when I say that, they get very excited because the license is what they are waiting on. And you can actually print a digital copy of your license. So you really don't need to a whole lot of phone calls. Ask when the system works. So that's what we are looking at, okay? Comprehensive reporting, intelligent reporting of data. So we actually know how many types of hospitals are there. We know the services that can be provided at each facility. Whether it's an ultrasound, there's a CT scan, there's an MRI, okay? You have those people to do. Of course, to get a CT scan and MRI, you must have a radiologist. The need for more specialty training. So it gives us, the government, data, good data. And the data is carried from what you supplied, which we came and verified. So it minimizes the guesswork as to what we have. So if you want to know what services can be provided at Kolebu, you know that. From Komfanochi, you have it. From Cape Coast Teaching Hospital, you have it. University of Ghana Medical Center, you should be able to even tell the bed capacity. All right? Because we collect that information as well. We are really doing this one, and as you can tell, we are going to what we call e-mapping, so that we can have the map of Ghana and tell you what every healthcare resource is. So if you are run out of a medication and you are driving on your way to Kumasi or Tamale, wherever you are going, you can, on the palm, find where the nearest pharmacy is. That maybe has the medication you're looking for. But that requires a greater integration with the Pharmacy Council, which we are working on. Management of data and the generation of statistics. Essentially, you have better data to inform decision-making. Then security and control system. No one person can carry you all the way through the registration process. So if someone, what do you call them? I'm a contractor, or I can do this for you, the person is probably not being truthful with you. No one person has access to carry you from registration to generation of license. The system does not allow. Even as a registrar, I can look at many things, but I can't perform many things. Are you there? So don't think that if you don't say that's not true. There's a lot of quiet security, and there's a trail, audit trail, who went into where and did what, okay? Very good. One of